stroke beyond the window period. We have already discussed about how to manage a stroke patient in the initial window period time. So medical management is for those patients who are either reporting to the hospitals after the prescribed window period. So what it is, firstly, we have to look at introduction of this. If a patient with acute ischemic stroke, if he presents after the reperfusion window, that is 4.5 hours for IV thrombolysis or 6 to 24 hours for mechanical thrombectomy. So medical management is to be done, and management is to be focused on the supportive care, prevention of stroke progression, secondary prevention, and early rehabilitation. These are the 4 points which are to be focused for medical management of any ischemic stroke patient. So first of all, what we need to do is we need to confirm whether the reperfusion window has passed or not. So before labeling any patient beyond the window, we need to ensure this, and we need to rule out large vessel occlusion, whether any large vessel is occluded or not, by doing DSA or perfusion imaging, because many patients even improve after 6 to 24 hours of the window duration for mechanical thrombectomy. And another thing which is a bit confusing is wake up stroke, or the last well-known time is not confirmed. Sometimes patient when he gets up in the morning and he feels weakness, so the exact duration of onset is not confirmed. So for those patients, we have to go for MRI diffusion flare imaging, and if there is mismatch, then we can go for even IV thrombolysis. Now, the most important part for medical management is the antiplatelet therapy. Aspirin is the most important and the wonder drug for this. We have to start with 160 to 325 milligram within the first 24 to 48 hours of the stroke onset. First, we need to rule out the intracranial hemorrhage by doing at least a CT scan or MRI. And then the daily dosing, here in India, we mostly use 75 to 150 milligram daily. And if thrombolysis has been done in a particular patient, then we have to delay giving aspirin or any other antiplatelet drug for minimum 24 hours. First, we need to rule out hemorrhage after doing CT scan, 24 hours after doing IV thrombolysis. Now, what are the indications for dual antiplatelet therapy, that is aspirin and clopidogrel combination? It is recommended only for the minor stroke, as Dr. Anil already discussed about the NIHSS scoring. So if your scoring is less than 3, or very less disability or very minor stroke is there, or if a patient has transient ischemic attack, that is no tissue damage is there, but the hemiparesis or some weakness was there for less than 24 hours, then we can go for dual antiplatelet therapy. And it is to be given for minimum 21 days. We can give up to 90 days, but minimum 21 days of dual antiplatelet is required. And then we can shift to single antiplatelet therapy. It is not recommended in routine use for moderate or severe stroke, because then the risk of bleeding, the intracranial hemorrhage will increase. Now, what is the role of ticagrelor in the recent 2026 guidelines? They have also mentioned about ticagrelor. If the stroke is minor, or if the patient is having high risk of TIA, that is ABCD2 score is more, and if the ipsilateral intracranial artery shows stenosis of more than 30%, that is the same symptomatic side has more than 30% of stenosis, then we can go for ticagrelor, 180 milligram loading dose, and then 90 milligram BD with aspirin. And it is to be given only for 30 days, not for prolonged duration, because it may also increase the risk of bleeding. Next is the blood pressure management, how to manage blood pressure in a patient with ischemic stroke. If the patient has not received thrombolysis or thrombectomy, then we need not to treat hypertension unless the BP is more than 220 by 120, or if there is any other indication, like there is another comorbidity, like patient is in acute MI or aortic dissection or heart failure is there, then we need to reduce. Otherwise, we can maintain BP around 220 to 120. And if the treatment is required, then BP is to be lowered by only 15% in the first 24 hours, because if we aggressively lower the BP, then reperfusion injury, there are high chances of reperfusion injury. As already discussed in previous lectures, that penumbra and core. Core is the part of the brain which has already been damaged because of stroke, and penumbra is the surrounding tissue. But if we lower the BP, then the penumbra will also convert into core. So we need not to lower BP aggressively, and hypotension and hypovolume has to be avoided. And after the acute phase passes, then we can target the BP for less than 130 to 80 milligram of mercury for secondary prevention. Now, this is a simple rule we can remember. This is 185, 180, 220, and 15. 185 by 110 before thrombolysis. Uh, If the BP is higher, then we need to reach till this goal before thrombolysis. 180 by 105 after thrombolysis or thrombectomy for at least next 24 hours. 220 by 120, as already seen in previous slide, threshold if no treatment is required, if there is no reperfusion treatment is given. And 15% is the maximum recommended goal for BP reduction in the first 24 hours, if at all treatment is required for hypertension. Now, next, moving on to the statin therapies, high intensity statins, unless it is contraindicated due to any other reason, we have to start. Atorvastatin is preferred 80 milligram once daily, and rosuvastatin, these are optional. Either of these has to be given. And the goal of LDL is less than 70 in atherosclerotic strokes. Anticoagulation, there is no routine use of anticoagulation, that is heparin or low molecular weight heparin, in any acute ischemic stroke patients to prevent the progression or recurrence. But in cardioembolic cases, that is if the patient is having atrial fibrillation or if the ejection fraction is very low, and if you suspect that the stroke is because of any cardiac event, then we can start long-term oral anticoagulation, and it depends on the size of infarct and whether there is any hemorrhagic transformation or not. So there is a commonly practiced approach of 1, 3, 6, and 12-day approach. That is different clinical scenarios. If the patient had only TIA, that is there is no tissue damage on MRI, then you can even start anticoagulation within first 24 hours. If minor stroke is there, that is NIHS is less than 8, then on day 3 we can start anticoagulation. For moderate stroke, score of 8 to 15 on day 6, and if the patient is having severe ischemic stroke, a large part of the brain tissue has been damaged, then at least we have to wait for 12 to 14 days before starting anticoagulation. And for non-valvular AF patients who presents with stroke, the preferred agents we can directly start now direct oral anticoagulants, which are oral. It is apixaban, rivaroxaban, dabigatran, or edoxaban, and warfarin is to be used particularly if the patient had mechanical prosthetic heart valves or if there is rheumatic heart disease. Now, before starting anticoagulation, what we need to do, we have to repeat the brain imaging to exclude if there is any hemorrhagic transformation, if there is large evolving infarction and the significant edema or mass effect is there. Because if in these cases, if we start anticoagulation therapy, then there are high chances of intracerebral hemorrhage. Also, we need to ensure blood pressure is controlled and renal and hepatic functions are adequate and there is no active bleeding from any other sites. DVT prophylaxis, because if the patient is very low power, if the mobility is not good, then there are high chances of deep vein thrombosis. So intermittent pneumatic compressions for immobile patients, the most preferred technique. We can also use prophylactic dose of low molecular weight heparin or unfractionated if the bleeding risk is acceptable. But in the recent 2026 guidelines, they have preferred intermittent pneumatic compressions as compared to these anticoagulants. And using only the elastic compressions is not good enough for initial few days if the patient is immobilized. Now, blood sugar management, the target glucose is 140 to 180. Hypoglycemia has to be treated promptly. There is no need of aggressive sugar control. That is, if you are treating and the sugars are less than 130, then it is not recommended. 140 to 180 is the target range. Temperature, if fever, we have to treat it aggressively. We have to find any focus of infections. Most commonly, urinary tract infections or any lower respiratory tract infections are common in stroke patients. So we need to acknowledge those things also. Swallowing evaluation is a very important thing, which sometimes we miss, because if the patient is having dysphagia, he may later on develop aspiration pneumonia. So whenever we receive a patient of a stroke, we have to perform a bedside swallow test. One test known as GUS test is there. There are a few points for that. We need to acknowledge everything, whether the patient is able to swallow saliva, whether he is able to cough or not. So after performing that test, if we feel that everything is fine and his swelling ability is fine, then only we need to start oral. Otherwise, we have to give RT feeding. Rehabilitation is already discussed by sir in the previous lecture. Early mobilization is highly recommended if the patient is medically stable. Physiotherapy, occupational and speech therapy are all those very important aspects for stroke rehabilitation. And finally, etiology directed secondary prevention. We need to evaluate. We have started managing the acute stroke, but why this stroke happened? So we need to prevent this. So secondary prevention point is depend on different etiologies. So if carotid stenosis is there significantly, Mostly, if there is more than 50 to 90% of stenosis, we may go for revascularization techniques, that is carotid stentings. And whether the stroke is from any cardiac site like cardioembolic stroke, so what we need to do, a basic ECG, echocardiogram to check for ejection fractions, and Holter monitoring. Ideally, guideline recommends for 28 days Holter monitoring, but it's usually not feasible in a country like India. So we need to at least go for 24 to 72 hours of Holter monitoring to catch any paroxysmal atrial fibrillation events. Small vessel disease, lipid profile, and all those things, hypertension is to be ruled out and managed properly. And hypercoagulable states in some young stroke patients, there are some genetic causes where the patient have hypercoagulable conditions like antiphospholipid antibody in young females or protein CNS deficiency. So we need to go for that thrombophilia workup also. And if those reports are positive, then we need to give anticoagulation to those patients. So to summarize this lecture, for a patient presenting after 24 hours, that is after the window period of IV thrombolysis and mechanical thrombectomy, if you have a patient with ischemic stroke, first of all, you need to do CT or MRI to exclude hemorrhage, then aspirin 300 milligram loading, and then 75 to 100 milligram daily. We already discussed about the dual antiplatelet indications. Then high intensity statins to be given, and permissive hypertension. That is, we need not to treat hypertension if it's more than 220 by 120. Then only we need to treat. Glucose sugar range should be 140 to 180. Swallow assessment by Gus test to be done. DVT prophylaxis for immobile patients, and we need to investigate the etiology of stroke, and appropriate long-term secondary preventions are to be given, and rehabilitation is to be started as soon as possible. Thank you.